Hello and welcome back to the Middling Along podcast. I'm very excited to have back this time Dr Beth Thomas, who's not only a GP and a BMS accredited menopause specialist, but as any of you who might have been listening to the last time we had Beth on the podcast, she's also my sister-in-law, but she's also now working some of the time alongside me at Managing the Menopause as our clinical lead. So if you haven't checked out our website, that's managingthemenopause.com, and we work with companies and sometimes individuals on a one-to-one basis and do coaching. So yeah, please do go and have a look at our website and see what we are up to. Welcome back to the podcast, Beth.
Thanks very much for having me back. It's really nice to be here.
So slightly belatedly, because the conference, the British Menopause Society conference, actually happened at the end of June, we thought it would be really helpful to do a roundup, because you were there sort of both in person and online. I think it was across 2 days, about the sort of research that was presented, kind of new developments, new things that are coming to light in the menopause space, and maybe also talking about some of the new types of treatment that are going to be on the horizon here in the UK. There's one that's already available in the US if we've got US listeners, but isn't currently available here. So you were going to kick off and talk about a bit about cancer, which is something that we always get lots of questions about at the sort of the sessions that we run.
That's right, and there was quite a lot of emphasis about cancer and how it fits in with menopause care and how it fits in with HRT at the conference this time. So one of the things that we talked about and had some specialist oncologists in was talking about breast cancer, and obviously talking about the fact that we know that there's an association between HRT and a small increased risk of breast cancer. I think that's well known. We also know that that's very much less than the increased risk of being overweight, for example, and the risk that causes for breast cancer. We also talked about, which maybe some of your listeners aren't aware for, that when they've looked at the studies for breast cancer, it's very much only the combination HRT that seems to have that association, that when you're on the estrogen and progesterone, and that women that are just on estrogen because they've had a hysterectomy, actually there's no associated increased risk. And also that the risk of breast cancer only really starts kicking in after the age of 51. So if you're on HRT because you're going through an early menopause, then there is no increased risk if you're starting HRT in your 40s. It only kicks in sort of after, when normally your estrogen levels would drop off. And really they said, look, where we are with the breast cancer risk is where we are, that there's been 2 or 3 big studies in the last 30 years. There aren't going to be any more big studies, actually, that it's really not worth it in terms of big pharma's is money or
it's
interest.
Very hard to do anyway, isn't it, across
it's
that
really
long-term studies.
Yes. So the evidence that we've got is all that we're going to get, and really it's about counselling women very carefully and having a really individualised look at what their risk factors are and making sure they're on the right HRT for them. So that was one thing that came out. They talked a little bit about the new medications that are on the horizon for women that have got breast cancer, that are having menopause symptoms. So if you've got a history of breast cancer, particularly if it's estrogen receptive breast cancer, which about 80% of breast cancers are, then ideally we wouldn't recommend that women go on HRT. Obviously you've got a cancer that we know is being driven by hormones, so it sort of doesn't make sense to then give you those hormones. There are exceptional cases where women that do end up going on HRT because really they've tried all the other non-hormonal options and really their quality of life is so poor but that would be a decision that would be made very much with the breast surgeon and menopause specialist and the oncologist and the patient. But the really exciting news is that there is a new drug on the market called Veozah, or its proper name, which I always struggle to pronounce.
I know, me too.
Fezolinetant.
We'll all be saying it eventually.
Yeah, that's right. And this is a non-hormonal medication that's licensed for treating the vasomotor symptoms, so the hot flushes and sweats associated with menopause. It's been around for about 5 or 6 years. It works on, it's a neurokinin 3 receptor antagonist. So it works directly on the hypothalamus, which is the bit of the brain that controls thermoregulation, and it sort of blocks the chemicals that do that, and it moderates the thermoregulatory center. It's had approval in the USA, so it's available there. It's not yet approved in the UK or in Europe. It's NICE, which is our big regulatory body in the UK, is looking at it. We were going to get a decision in January, but I think, as far as I know, that's been pushed back to July of next year now.
Okay.
It's definitely safe. I think that the real concern is the cost. So I think that it costs, and this is what they say in the conference, about £540 per patient per month to be on it.
Okay, so that's expensive compared to HRT, for
That
example.
is expensive, yeah. So we will wait and see NICE's decision, but there are things out there that are going to be coming along.
And somebody would potentially be able to take that, and then presumably would be reviewed annually to sort of see if they needed to stay.
Yes, I would imagine so. I mean, I would imagine at that cost, it won't be something that you can just get from your GPs. It will probably come from a breast oncologist. They will be the ones that will need to prescribe it. I mean, there are, and we've talked about this before, there are other medications that women that have had breast cancer can have, non-hormonal medications such as venlafaxine and oxybutynin. So if anyone's listening that has been through breast cancer and has been told they can't have HRT and is struggling, please do go back to your GP, and there are options that they can try.
Yeah, and there's a fantastic podcast actually called Menopause and Cancer, and that they do sort of deep dive into a lot of this. So that's another good recommendation. And you said there was also quite a lot of discussion around endometrial cancer.
So this was probably the big take-home message, I would say, from the conference. So endometrial or womb cancer has hugely increased in the last decade in the UK. And the main reason for that is actually the increase in obesity in our society, because obesity is the biggest risk factor for womb cancer. But what we're also worried about is getting the balance right of HRT for women. So what we know when we give HRT, the estrogen is what treats the symptoms, and the progesterone is that protective hormone that keeps the lining of the womb thin. Because if you get thickening of the lining of the womb, that can potentially go on to become womb cancer. And the studies have shown that women that are on what we call separate component HRT, so they're taking both estrogen and progesterone in separate ways, and that's body identical. So our gold standard now is estrogen through the skin, and then that lovely Utrogestan tablet. But what we are finding is that your risk of womb cancer taking it that way is actually increased. And there's many reasons for that. Probably the biggest reason is that there have been shortages of Utrogestan, as we know, over the last year, and that's probably going to go on into next year. And so we are worried that there are women that are not taking their progesterone component because they can't get hold of it.
Or they're rationing it or something.
Or they're rationing it, and they're thinking, well, actually, I feel great just taking my patch. I mean, the tablet doesn't make any difference. And the other big concern is that we're seeing women going up on higher doses of estrogen, and they need that to control their symptoms. But actually, they often need an increase of their progesterone dose as well, and that's not always happening. So if you're on 100 patch or a 4 squirt of your gel, you really should be on double dose progesterone. And I think
that would be 4 tablets rather than 2.
Yes. So if you're taking 2 tablets, 2 weeks on, 2 weeks off, you would go up to 3 tablets. And if you're taking 1 tablet all the way through the month, we would recommend that you go up to 2 tablets. But that's something that really you should be talking to your GP about, and your GP should be putting that dose up. But I think that message has not necessarily filtered down to everyone. So yes, the biggest risk for endometrial cancer is obesity, and that's what's driven this huge increase. But there is this concern that we're not always getting the balance right. And if we don't always get the balance right in HRT between the hormones, even if it doesn't cause cancer, which obviously most of the time it wouldn't, it does often cause a bit of bleeding. And that brings with it a lot of anxiety, maybe some unnecessary investigations. And so, we really trying to look at how we can get that balance right. And I felt coming away from the conference that there was a feeling that going back to those combination products was actually not a bad thought. Whilst we really like body identical HRT, actually a patch that's got both the hormones in it, then that the woman
in the right ratio.
Yeah. And it shouldn't be discounted as an option at all.
Okay, interesting. I mean, it's always about balancing risk, isn't it? And it's an individualized discussion. But I guess if someone's listening and they're suddenly thinking, oh, I'm not sure about that kind of progesterone and thing, they should go back and see their GP or.
Yeah, and absolutely. And I think the big message actually is if you can't get hold of the progesterone, you think, does it really matter? Yes, it does.
Yeah, it really does. Okay, let's move on then and talk about next topic, which is nutrition and our microbiome. We're hearing a lot more about our sort of gut, or our friendly gut bacteria these days. But why is it so important for menopause?
Yeah, this was really fascinating. So we had a really good talk from a nutritionist, first of all, about what happens with our weight in the menopause. And so he said that the average woman gains about 10 kilos during their perimenopausal year. And the other really important thing is where you gain your weight changes, which I'm sure women listening are aware of, that rather than having it around your hips and bottom, suddenly for the first time ever, it's going around your stomach and you're getting that sort of protruding tummy. And that's important because that fat around your tummy also corresponds with fat building up around your liver and your heart. And that's got those associated long-term risks. Sort of depressingly, there was no quick fix or golden answer to what do we do about this. There's the evidence is there's no one diet that is better than any other diet. So for all of those that think maybe intermittent fasting, which is the latest thing, is the thing that's going to solve their problems, there's no evidence for that. Possibly the Mediterranean diet has got some other health benefits. For me, his take-home tips were, look, think about what you're putting in your mouth. Really, it should be 3 meals, 1 snack, and that should be it. Think about your plate size. Have your smaller plate. He talked about the rule of 20. So chew everything 20 times. Don't put anything in your mouth bigger than a 20p piece, and try and take at least 20 minutes to eat a meal, because it takes 20 minutes for your brain to get those satiety signals from your stomach to say your stomach is full. So we eat very quickly in this country. And I think what happens is we then overeat and don't recognize that we're full. So that was him. And he talked about the importance of the 3 types of exercise now. So it's not just cardiovascular, it's also strength, and it's also restorative, which is the sort of yoga and Pilates. So in an ideal world, we'd all be doing a bit of all 3.
With all of this spare time that we've got.
I know.
But we can try and get the balance.
We can try. And I think it's about putting it into your daily life. I think it's about making sure you try and take the stairs rather than the lift. I think about putting a standing desk in at work, about if you're a dog walker, getting some little hand weights to wear when you're walking as well. So you're not going to suddenly become a gym bunny. Most women, we haven't got the time to. So try putting them in. And then we had a really good talk from a Professor Jack Gilbert from San Diego, talking about the microbiomes and how what we eat affects the different type of bacteria in the gut. And he was saying that high saturated fat food increases the abundance of a type of bacteria called facilitative anaerobes, which are less good about breaking down adipose tissue, so tend to be more kind of fat friendly bacteria. He also said, and I wrote this down at the time because I was so fascinated, he was saying that your biomass in your body in your gut of bacteria when you go to bed is about 0.5 grams. By lunchtime, it's 1.3 kilograms. So he was talking about how quickly bacteria replicate in the gut. So you put some food in and they massively replicate. And so he was saying the first bit of food you put in your body in the morning is really, really important because it influences the type of microbiome you're going to have in the gut that day. I mean, some of this went over my head, but he also talked about that there are toilets in development that will sense your current microbiome. So you do your morning ablutions, it will take a sample of your stools, and it will then tell you that you are high in lactobacilli or low in E. coli, and actually what you then need to eat that day to try and get your gut microbiome.
Sounds like something out of science fiction, but yeah, I well believe it.
It is coming. But he talked a lot about how the fact that the loss of estrogen also acts directly on the gut to affect, it increases the number of protobacteria and it changes the sort of gut bacteria makeup, and again makes it much more likely that you're going to have localized inflammation, and then that inflammation has effect on the rest of your body. And there's some evidence that HRT reduces that unhelpful protobacteria that we get in our gut. So definitely estrogen has effect on our gut microbiome, but probably more important than that, I would say, was the first thing you put in your mouth in the day. So I was all getting into missing my breakfast, getting to 11 o'clock and having a chocolate hobnob. Oh, in those days have gone for me now. I'm not
This is
doing
the
that anymore.
anti, what is 16-8 rule or
Yeah,
something?
exactly.
Interesting. And I was just thinking about microbiome as well, because that sort of, again, with the drop in estrogen, like the pH in the vagina changes. So your vaginal microbiome also changes. This is why people are more
Yeah,
prone to infection. So
yeah.
yeah, it's all about the microbiome.
I would say microbiomes is going to be the next big thing for us over the next 10
Mm,
years. Though we're seeing already
that
that we're
personalized
thinking
medicine, kind of
personalized. Yeah,
targeted.
there's some evidence that your gut microbiome has an effect, is linked with autism spectrum disorder, that when people have had fecal transplants, which we sometimes do for gut conditions, that they reported some changes in their personality. I mean, there's a massive link between your gut health and
Mm.
your brain health, and that is, that's going to be huge.
Let's touch a little bit up on the next topic, which was the sort of ethnic disparities in terms of both how people experience menopause, but sort of menopause care as well.
Yes, and we had a really good talk about this. And as you say, there's two real evidence, two real prongs to this. One is that we know in the UK that there is a barrier to good menopause care for some different ethnicities. And we also know that most of the media portrayal around menopause, the posters, the things we see on TV are white women, aren't they? And that really needs to change. There is a lot of cultural and personal barriers to accessing menopause care amongst certain ethnicities. It may just be as simple as health literacy, but often they said that 78% of women from a Pakistani background actually don't know about the menopause, that it's not sort of talked about in that culture. Most of the resources in this country are in English. And then they talked a lot about how menopause presents quite differently in different ethnicities, and also the age it presents at. So in Caucasian women, the average age of menopause is 51. But in Indian women, it's 46 years old, and it's even lower in South Asian women. And they talked about the difference in how menopause presents. So Afro-Caribbean women tend to have more vasomotor symptoms, so more of the flushes, and
Mm.
often have a longer period of menopausal symptoms and have worsening weight gain, but it doesn't seem to affect their sexual function as much. Whereas South Asian women tend to have fewer vasomotor symptoms, and that might be put down to the fact that they tend to have a diet that's very high in soy and those lovely isoflavones that we know have some estrogen containing properties, but they actually tend to have a larger decline in sexual function and a worse decline in their joint pains
Mm.
compared to Caucasian women. The other group that we do need to be concerned about is South Asian women, because we know that if you've got a South Asian ethnicity, your risk of developing diabetes is increased compared to a Caucasian person. And we know, as we've talked about on this podcast before, about that link with worsening cardiovascular risk when you go through the
Mm.
menopause, that loss of estrogen has on our heart health. So in South Asian women, they've already got that sort of background increased genetic risk because of their ethnicity. That's a population that really we would like to really kind of reach out to and talk to them about the benefits of HRT. So lots, I think, there that needs to be worked on. I think there's still a preconception, and it's probably true that menopause is something that if you're a rich, white, educated woman, you can tend to access help. But if you're not in that particular socioeconomic group or demographic, then it can be more difficult.
As the sort of the rates of take up of HRT are much lower, aren't they?
Yeah, and I think you and I, Emma, we're in a bit of a bubble. Obviously, we talk about menopause a lot, and it feels to us that even we talk about knows about HRT and has made a choice about whether they want to go in or not. But actually, across the UK, of perimenopausal women, only 14% are on HRT. Now, I can't believe that that's because 86% have decided not to take it. I suspect it's because there's a big proportion of that group haven't asked for it or haven't been offered it,
Mm.
or isn't that conversation's never been had with them.
Oh, so you talked a little bit about Veozah, but I think again one of the questions that often comes up in sessions is around what are my options if I don't want to take HRT or I can't take HRT.
Yeah, and there was a really good section on non-hormonal options and alternative options that you can use. Then I think the bottom line is that there haven't been that many studies because, again, there's not that much money in it for big pharma to do. There are some new nice guidelines coming out next year on non-hormonal options for menopause symptoms, so we will look out for those. About 90 to 95% of women will have tried some over-the-counter supplements for their perimenopausal symptoms. So we've all tried something.
And it's big business.
It is big business. Bottom line is there's really good evidence for lifestyle changes. So there's good evidence for losing weight, stopping smoking, increasing your exercise in terms of improving your menopause symptoms. Reducing caffeine and reducing alcohol are really important things to do. Is good evidence for talking therapy, so cognitive behavioural therapy has got really good evidence for helping with menopausal symptoms. And I'm sure I've talked about it before. Dr. Myra Hunter is the lead in this, a psychologist that's written a couple of books about how to manage menopause symptoms with CBT that you can get anywhere, I think. Then she went through some specific ones. So for bladder and cystitis symptoms, there's quite good evidence for a herbal supplement called D-mannose, Mannose. And I recommend that to a lot of patients, men and women, that are getting some kind of irritated cystitis symptoms. And also for hyaluronic acid. Apparently that works for that. We know about vitamin D and calcium. That's the one supplement I take is vitamin D. And that's about our bone health and reducing the risk of getting fractures. There is some evidence for vitamin E for helping with vasomotor symptoms. So that's one that possibly is worth trying to take. There's really good evidence for relaxation therapy. So yoga, Pilates, mindfulness, acupuncture, that's all got quite good evidence behind it. And then going through the sort of specific ones that you can buy over the counter, I would say the bottom line is there's a strong placebo effect. There's not really massively good evidence for any of them. Wild yam has no benefit at all. Black cohosh possibly can have a bit of effect, but it's not advised in women that have had a history of breast cancer. St. John's wort definitely does have a beneficial effect on mood symptoms. Ginkgo biloba, is that how you pronounce it? That's supposed to have some beneficial effect on brain fog. And the other one she talked about was Agnus castor. Possibly there's been a recent study that's shown some benefit for that. So they've all got some risk associated with them. We don't really have that many great studies. But, most women will have tried something at some point, but probably none of them are brilliant, I think, was the bottom line. I think there's a little bit of concern about Chinese medicines as well, because there's really no studies about those, and they could be quite potent.
I mean, and there's always going to be somebody who's like, oh, I tried this and it made a massive difference for me. And, whatever it is, there will always be somebody who's had a life-changing kind of result.
And that's absolutely fine. I think my takeaway point would be, don't be disheartened if it doesn't make a big difference for you, because probably the evidence is that it is minimal, the benefits you get from them.
Yeah, spend your money on vitamin D.
Vitamin D,
maybe
and
magnesium.
nothing replaces exercise, stopping those cigarettes, and reducing that alcohol.
And all of those things as well feed into that reduced risk of cardiovascular disease. And obviously that's been the sort of the theme for World Menopause Day this year. But you were saying when we were talking offline, you were talking about some really interesting things that kind of contribute to elevated cardiovascular disease risk. So can you talk a bit about that?
This is really interesting. And there was a talk by a doctor called Professor Angela Mass, who is a cardiologist who really specialises in women's cardiovascular disease. And she was saying that women present quite differently to men with cardiovascular disease, that they tend to get spasm of the arteries as opposed to blockage of the artery. So often they will have normal angiograms. That's the test we do to look at whether an artery is blocked, but that doesn't mean that there isn't problems going on. And she was saying that there's a lot of female-specific risk factors for heart disease that don't really get discussed in the same way that smoking does. So anything that causes general inflammation in the body will increase your risk of heart disease. So things like rheumatoid arthritis, lupus, MS, thyroid disease, which all tend to affect women much more than men, have actually got quite an increased risk of cardiovascular disease associated with them. She also talked about female only condition, so preeclampsia, so that's high blood pressure in pregnancy, that is hugely associated with developing high blood pressure in later life. So if you've had preeclampsia, it's really important that you get your blood pressure checked once a year, I would say, because the chances are it's going to go up at some point. And also she was talking about things like gestational diabetes. So women
Yeah.
that have had diabetes in pregnancy, again, really high risk of going on to get diabetes in later life. And actually we know now should be having their sugar levels checked at their GP surgery once a year. But interestingly, also endometriosis. She was saying that there's systemic inflammation. So endometriosis is an inflammatory condition, but that inflammation, all those inflammatory cytokines
Yeah.
and cells there, they go all around the body and they cause immune dysfunction. And there is a link with an increased risk of cardiovascular disease with endometriosis. There's a link between recurrent miscarriage and increased risk of cardiovascular disease.
Wow.
Yeah. So all of this, she was saying, look, we need to raise awareness of female
Yeah,
only
we don't want to
conditions.
scare people, but
Don't
it's
want to scare
helpful
people.
information to be aware of
It
because,
is.
we all know our own bodies best of anyone.
Absolutely. And I'm not scaring anyone, but I'm saying, look, if you've had those conditions, then it would be sensible to think about having your blood pressure checked every now and again. And actually, again, the things that we know that are really important to keep your blood pressure down are being a normal weight and having a diet that's not too high in salt and keeping your alcohol down. So again, just another reason to try and really look at tackling your lifestyle. And as we've talked about before, Emma, we know that risk, that estrogen is protective against heart disease. So when we go through the menopause and our estrogen falls off, that our risk of heart disease does increase and we start catching up with the men. And so again, we talked about this before, that I think the menopause, for all its challenges, can also be seen as a real opportunity to say, okay, this is it. What can I do really? I want to be fit and healthy into my 70s and 80s. We don't know
Yeah,
what's going to
it
happen
is
to any of
literally
us.
our midlife MOT, isn't it? It's like
Absolutely.
check for the warning lights.
Absolutely. Absolutely. And you can put in changes at 50 that will have a really, really important impact on you long term. We've got another 35 years of our life to go. That's a long time,
Well, at
isn't it?
least hopefully. And actually one of those things I think again that makes a really really big difference, and I think a lot of the time that's underestimated, is sleep. And it's something that so many of us struggle with in some way, shape, or form, and it just has such a big kind of knock on impact to so many kind of areas of life. But yeah, tell us about the sleep research that.
Yeah, there were a lot of pens at the ready for the sleep talk that we had. I think we were all
Eager
desperate
beavers.
to be told what we needed to do and to improve our sleep. And it was a doctor called Dr. Hadeen Joff, who was an expert in menopause and sleep. So the first thing she sort of pointed out was, well, what is insomnia? Because a lot of people come in and say they've got insomnia, and actually they don't. She said, so it's having disturbed sleep for more than 50% of nights for at least 3 months, and it resulting in daytime dysfunction. And it's about 10% of the population suffer with chronic insomnia. So that's a lot of people, isn't it?
Wow, that's a lot of
Yeah.
tired, grumpy
Yeah.
people.
However, she also said it's normal to take up to 20 minutes to get to sleep. So I think don't panic if you feel you're lying there for ages. Obviously, all the usual sleep hygiene things, don't look at the clock, make sure your room's the right temperature, make sure you've wound down before. But what really resonated with me, she was saying that the evidence is that the more important thing about sleep is not how long it takes you to get to sleep, but what she calls WASO, wake after sleep onset. So how often you wake up in the night and how disturbed your night's sleep is. And this is something that I see all the time with women going through menopause, is they say, I get to sleep okay, but I wake at 2 because I'm hot, I need the loo, my mind's racing, and then I wake at 4 and then I can't get back to sleep about that. And I think one of the problems is that when you've got disturbed night sleeps, you're not getting into that restorative stage 4 sleep, that really deep sleep. You're kind of
Yeah.
constantly in those lighter sleeps. And often if you're having sweats in the night, you're waking up and then not remembering that you're waking up. You're waking up because you're hot, and we all know that that's a huge problem in the menopause, is fatigue, isn't it, the next day? But also sleep is so important for our long-term health, isn't it? We know that it's important for keeping inflammation down and our effect on our heart and all the rest of it. So in terms of what you can do to help insomnia, she said definitely estrogen's got some benefit. CBT is really effective, actually. That was a good message that came out of it. And there's a great app that I know in Surrey, where I practice, that NHS patients can access, called Sleepio app. I think anyone can access it, but I know in large parts of the country it's available on the
Yeah,
NHS.
I know
And
we
that,
had Zoe, Dr. Zoe Shadell, who was talking about CBT and Sleepio and how
yeah, yeah,
good that is. So even if you
yeah,
can't access it through your GP, presumably it's worth.
yeah,
It's
it's
not.
worth
It's not
paying.
hugely
I don't think it's
expensive.
hugely costly. And I think that gives you very specific recommendations of what to do to try and improve your sleep. Actually, interesting, no benefit from exercise to help with sleep if it's done too late at night.
Mm.
And she suggested that some antidepressants also actually do help with sleep. Yeah, so it doesn't matter about your total hours, it's about whether or not your sleep is interrupted. So you can be, if you're just sleeping 5 hours a night, you're probably fine if you're going to bed at 11 and waking up at 4 and sleeping through. But if you're going to bed at 10 and waking up at 7, but having 3 wakes in that night, you're probably not getting a great night's sleep.
And you might not necessarily, as you said, you might not necessarily be aware that you're kind of got all of those little micro
Yeah,
wakings, but you'll
yeah.
still feel not feel refreshed the
Yeah,
next day.
absolutely. Yeah, that's right. And so again, think about another reason to maybe think about HRT, but I think sleep hygiene, relaxation techniques. Why are you waking? You're waking because you need the loo. That can something can be done about, or you're waking because you're flushing and sweating. Think about doing
And there was an
something.
interesting reading something about your kind of cortisol levels as well. So people with that kind of chronic levels of stress, your cortisol levels are building up earlier. So it's that kind of gradual build up of cortisol that wakes us up naturally. So if that is kind of skewed and it's happening because you've kind of got higher elevated levels of cortisol
Yeah,
anyway, does that make sense? That
yeah,
you're
that
kind of
makes
it's
sense.
kind of pushing your wake up time earlier,
Yeah,
and then it's
yeah,
harder to get back to sleep because you've got the kind of that elevated cortisol that your
yeah.
body is going, wake up, time to go and do all the things.
Yeah, that definitely makes sense. Melatonin has got good evidence. It's really frustrating that melatonin is so
Mm.
difficult to get hold of in this country. Obviously, it's available to buy in lots of other countries, but you can get it on prescription if you're over 55 in this country. So
Oh,
something to think about if you're suffering with insomnia and you're over 55. You can talk to your GP
yeah.
about a trial of melatonin.
And the alcohol, I find is a big one for me. That the days if I do drink probably more than one or two glasses, it ruins my sleep.
Yep, there's really good evidence for that. And I was saying to you before that amongst my friends, it's known as Beth's rule, that for years now, I won't drink after 10:15 at night because I had this I got it down to a fine art because I was like, actually, what happens is you've had a drink or two and you're feeling relaxed and you're having a lovely time out with your friends and you think, I'm just going to have one more. But that one more that you have late at night, you don't actually get the benefits. You don't need it, but
Mm.
it's so terrible for your night's sleep. It's so terrible, and it really causes you to wake up at 2 and you need the loo and you don't get rested sleep and you feel, I think, anxiety, that next day anxiety after any alcohol is much worse in those menopausal years. I have pulled my 10:15 rule down to 9 o'clock now as the perimenopause
I love
kicks
it.
in.
I think we should all adopt that. Beth's rule.
Yeah,
I'm rolling
9
that out.
p.m, no alcohol after that. And then it's kind of mainly through your body, hopefully, before you go to sleep, and hopefully it's not too bad. And
Yeah,
obviously keeping your alcohol down to a minimum is also going to be helpful. But what's
absolutely.
life without the occasional glass of wine? So
Well, I think more and more people are kind of doing that kind of cost benefit analysis and going, do you know what? It is just not worth it for me anymore. And for some people, it's just easier to do all or nothing and
yep,
just be like, I don't drink anymore. And fair play to them for that. We're
yep,
not quite there
absolutely.
yet, but
No.
you never know. Never know. Anyway, thank you so much, Beth. I think it's absolutely fascinating. I'm totally fascinated by the microbiome stuff. Really interesting about all of those kind of risk factors for cardiovascular disease. We don't want to scaremonger anyone, but kind of it is back to that thing of knowledge is power. Understand kind of what's going on for you. Be proactive, I guess. And if you don't feel like you're getting anywhere with your GP, what are people's options? I mean, they second opinion at the
Second
practice.
opinion within the practice, find out who it is in the practice that's got an interest in women's health. I really think the landscape is changing in general practice now. We're all
Mm.
upskilling hugely. So even if you went a year ago and felt that you were fobbed off, please do try again because the chances are someone in that practice has really done their education and is understanding the importance of offering really good choice about menopause care to women.
Yeah.
And there's, it's a whole nother podcast, but there's a lot coming out about should we be offering a menopause check to over 40 women and on the NHS. So watch this space. This is not going anywhere.
Definitely. We'll come back and talk to us about that another time. Thank you, Beth.
Thank you very much for inviting me back. Lovely to see you.
You've been listening to the Middling Along podcast. Do remember to subscribe to be notified when our next episode is live. And why not visit the blog at www.middlingalong.com to sign up to my newsletter as well. I do hope you enjoyed listening today. If you did, I'd be really grateful if you would consider leaving a short review, as that helps people find the podcast and helps get it noticed. Hope you can join us next time. Goodbye for now.